Good afternoon. It's 4 minutes past 4. A warning in advance, this is being recorded. My name is Dr. Christian Grove. I'm the chair of the Department of Community Health and Social Sciences, and I'm absolutely thrilled to present what's going to be the first our MS degree grand rounds. But I am going to turn it over to Dr. Chris Palmetto for official introductions. But thank you everyone for coming out today.
Thanks, Christian. Hello, everyone. As you're pouring in, and again, welcome. My name is Chris Palmetto, and I co-direct the MS and Health Communication for Social Change program with Scott Ratson, who will be moderating the Q&A later on. And yes, this grand round is sponsored by our program, so check us out in the chat if you're interested in learning more. I'm going to put that in right now. So there you go. And as a way of recognizing our fabulous students, I'd like to ask Health Communication for Social Change students, I can recognize your names, and including alumni, which we now have, to send me their questions, and I'll share one or two at the start of the Q&A, or invite the student to ask the question directly if they want to do that. So back in the last century, when I was just starting my career in health communications in Portland, Oregon, I found myself at an important health policy conference for political leaders and industry executives and the like. And one of the expert presentations was on the public opinion of healthcare policy. And it blew my mind. The whole concept of public opinion was still new to me. The national healthcare conversation was starting to really heat up. The presentation that day was compelling and insightful. And obviously it was given by Mollyann Brodie, or I wouldn't be telling you this story. Molly, I believe you were still completing your doctoral degree at Harvard. And if I recall correctly, you were co-presenting with your faculty mentor, the legendary Bob Blendon. And it was a wonderful display of insights, but also the power of faculty mentoring was on display, which I underscore because it's something very important to us here at this school. So soon after receiving her doctoral degree, Dr. Brodie joined the Kaiser Family Foundation, and since that time has grown the role of public opinion into a major function for KFF. And now Executive Director of Public Opinion and Survey Research, Dr. Brodie's work focuses on understanding public knowledge of healthcare policy issues and the role of opinion in policy debates. And along with overseeing all of KFF's polling, Dr. Brodie also serves as Senior Vice President for Executive Operations and liaison to the Board of Trustees. So although she's well qualified to speak about leadership and management, we are all fortunate to be able to be here today to learn about public opinion data for pandemic communications from Dr. Mollyann Brodie, one of the nation's top leaders on the subject. Molly?
Thank you so much, Chris. I totally forgot about that conference, but I will second the importance of good mentorship and of working with professors and scholars and teachers who really want to help you along and really help and give you those opportunities. And Bob Blendon was and is still one of my foremost mentors, and he was just excellent at that. I am going to share my screen. Let's just make sure. Great. Somebody, yep, Scott, give me the thumbs up. Thank you. Okay. Well, I'm very happy to be here. I wish we were in person. I really hate speaking to a screen and trying to see you all at the same time as I look at my notes and look at my slides, but I'm going to do the best I can with the limitations of a pandemic presentation. For 25 years, as Chris alluded to, I've built a career as a public opinion and survey research expert in the health policy arena. But my understanding is that many of you are communication scholars and specialists and part of the Health Communication and Social Change program. So my hope today is to share with you how I think about public opinion data and how I think it can be useful in communication efforts. Now, I'm going to basically answer the question of why do we at KFF devote so much effort, so much resources to conducting and analyzing and disseminating our public opinion results. I guess what I'm hoping is that if I share my why, it might help you all think of additional ways you might find to use polling data to be useful in your own work or your own communication efforts. What I'm going to do is I'm basically going to use two case studies, one from the past 2 years of the global pandemic, and then one from more than a 20-year policy discussion about how to lower prescription drug prices. I'm going to use these to illustrate how KFF uses polling, but do please keep in mind that this is from a practitioner perspective, not a scholarly perspective, nor as someone who's designing a specific communication activity or a specific communication campaign. So I'm really thinking about sort of broad practitioners' take on why public opinion data is necessary and I think critical to shedding light and illuminating the path forward in health policy debates, or perhaps, as in the first case, a global pandemic. So who's KFF? We try not to refer to ourselves as Kaiser Family Foundation anymore because we were just having to say everything we were not. We are not associated with Kaiser Permanente. We are not a family foundation. We're not a grant maker. So what is KFF? Well, KFF is a national nonprofit information organization, and we focus in national health issues. At the core, we fundamentally believe that information that is timely, relevant, and unbiased can make a difference for people in the healthcare system. We do our work and produce information basically 4 ways: through policy analysis and research, through polling analysis and survey research, in-depth independent journalism, KHN, you may be familiar with that, and through our social media impact and public health campaigns. Our audience is policymakers, journalists, the health policy community, and the public at large. So here's our why. Here's why we spend so much time and effort and resources really on polling. First off, in a $4 trillion industry, we believe and want to make sure that there's an independent, unbiased source of information that's in the public domain and that's on the public record. We want to provide information, in a sense, to be a balance to the moneyed special interests. We know they're spending a lot of time and energy trying to figure out messaging and framing and positioning themselves. And we want to just make sure that that same information is available more publicly. We also, and really when people ask me why I do my job every day, we really believe that the public deserves a voice in the system. And we want to make sure that people, and particularly groups of people who don't often have a seat at a political table, have that voice through our data. We make sure our samples and our methods allow us to present representative data of historically marginalized groups in our society. We often do oversamples of Black adults, Latino adults, Asian adults. We also make sure that we can represent the views of those who are particularly disadvantaged or in particular need in the healthcare system, like the uninsured or the chronically ill or those with serious conditions. Thirdly, in contrast to most media polls or those that you might see conducted by advocacy groups, we pay special attention to information about public's experiences, their perceptions and their knowledge, in addition to their opinion. And we try to make sure that people's real life experiences and how policy is actually affecting people in their lives is front and center as we present our data to policymakers and the media. And then lastly, it's not that the public's always right, but by understanding where the public is, we often find where leadership is necessary and where public education challenges exist. And we try to shed light on that. Now, certainly we know at the end of the day, we can collect all this information and do a great job doing all this measurement, but it can't just sit on our websites or at our desks. It has to be made to be timely and get in the hands of decision makers when they need it, if we're going to make sure that this information becomes part of all the policy debates and discussions and can actually make a difference for people. So going on to case study number 1, the case of public opinion during a pandemic. I'm going to spend the very bulk of my time on this case study. The second one is going to be really short. But to be honest with you, I've been presenting data from the KFF COVID-19 Vaccine Monitor, which I'll describe in a second, for over a year. And in all those presentations, I'm really focused on what we're learning from the data, how it can impact current efforts in vaccination outreach and things like that. But for today, and just to give you a heads up, I've pivoted and I've just picked a few examples from the project that I think really can illustrate the different kinds of ways that we use polling data. But of course, in the Q&A, we can always talk more about what we learned from this project if you'd like. Okay, so what is the COVID vaccine, the KFF COVID Vaccine Monitor, the CVM as we call it? Like many organizations, and probably like many of you, at the start of the pandemic, we pivoted. And we adapted all of our monthly health policy tracking surveys into a new project called the KFF COVID Vaccine Monitor. And the goal of this was to capture the dynamic nature of what was happening for people as they were learning and as they were making decisions and as vaccine rollout was happening. We wanted to provide the data and the information in real time to those who were on the ground and who would need it most as the vaccination efforts were rolled out. Method-wise, the surveys were probability-based samples. Interviews were conducted in English and Spanish. We included oversamples of Black and Hispanic adults to make sure we could speak about the experiences of some of the groups that had been disproportionately affected by the pandemic. And in certain months, we also included other oversamples of important groups to the pandemic, like parents when it came time to rolling out children's vaccinations, or rural residents, as that became a big question and issue on people's minds. So I'm going to start sharing some of these data points, and just as a key, you can see at the very top of the screen, I've put a blue bar with a kind of a key to which type of information I think this is an example of. So whether it's, an example of providing independent, timely information, whether it's providing information that helps with public education purposes, shedding light on experiences, or giving people voice in a system, just so you can get a sense of how I'm thinking about these as examples. But of course, many of these pieces of data can be used for a variety of those purposes. So certainly, it was just sort of a map for you. So let's start here with the main question that we've been tracking in every survey since the beginning of December. And this was looking at people's vaccination status and their intention to get vaccinated. We divided people into 5 categories. The shades of blue are those who are interested in getting vaccinated. The dark blue are the people who actually got a vaccine. The royal blue are people who were interested in getting it as soon as possible. The light blue are people who are in a wait and see mode. They still had things to learn. They wanted to understand more before they got vaccinated. The green bars were people who told us that they would only get vaccinated if it was required. That's light green. And then the dark green were the people who told us they were definitely not going to get vaccinated. So a couple, I think, things to take away from this chart over time. First of all, I think we really have to stop and remember the rapid increase sort of in the dark blue bars. I think it's easy now, because we've been so focused lately in the unvaccinated and those who did not get a vaccine, to sort of forget kind of how fast vaccine rollout happened and vaccine uptake became sort of the norm, right? So from January, when just 6% reported being vaccinated and another 41 were eager to get it as soon as possible, by July, we were up to 67% of adults saying that they were fully vaccinated. And I think we have to remember that there was a rapid increase in uptake. The second real takeaway from here is you see the shrinking sizes of that light blue bar going from the bottom to the top. And that is that the wait and see category shrunk over time as people learned what they needed to learn, got comfortable, got the information they needed, and moved themselves into the vaccinated category, basically. And then the third thing to take away from this is how stagnant the dark green part of these bars were. So the definitely not group, way back in December, 15% of the population of adults told us they were not going to get a shot. And even in January, 14% told us they were not getting a shot. This is a group that has stayed very stagnant and very set in their opinions over the time frame. Now, given our design and our goals, we were also able to focus by sharing information and tracking changes among subgroups of the population. So what this shows is the picture as of January of each group in our population, and what shares of those groups are vaccinated, the dark blue, or sitting on the fence, wait and see in the middle, or definitely not. So you can see at the very top are the groups in our society that are the most likely to be vaxxed. That's self-identified Democrats, seniors, and those who are most educated. At the bottom of this chart, you see those in our society who are least likely to be vaccinated, and those are people with lower levels of education, rural residents, those who self-identify as Republicans. But you also, it's really important to notice here that across all these groups, at least 6 in 10 members of all of these groups are vaccinated. And in no case are all of these groups monolithic in their vaccine intentions or activities. So that is across the board here. There are people who are vaccinated, people who are still sitting on the sidelines, but saying they're interested, and people who are definitely not. So what this sort of data allowed us to say over the course of the year, and the key communication from this, is that there was no group that was or remains monolithic in their vaccine intention. And it helped I think, counter some of the conventional wisdom that as we talk about the groups who are least likely to be vaccinated, there's a sense of suggesting that it's everybody in that group. And with a chart like this, we can easily help people to understand that the vast majority of most groups is already vaccinated. And lastly, as an example of this sort of independent, timely information, we were able to track the dynamic nature of this uptake over these subgroups. So here I'm just showing you partisan identification. And we all know that very early on, political polarization of the pandemic became a key factor in national discussions. And so we were able to see and shed light throughout the year on how early on there was a small gap by partisanship, sort of January, February, March. You saw Democrats were slightly ahead of independents and Republicans in terms of their uptake of the vaccine. But by late spring, that gap had really grown. And since then, Democrats have been 20 to 30 percentage points more likely to report being vaccinated compared to Republicans. And that's been the picture ever since. So what this means is that early on, when we talked about the unvaccinated, they were sort of equally likely to be a Democrat or Republican. But today, 2/3 of all those who are remaining unvaccinated adults identify as a Republican. So if you think about these first three slides together, they show the kind of data that wasn't available through any of the federal sources, particularly on the timeliness and particularly to be able to do the deep dive, tracking that dynamic nature among the subgroups of the population. And this information was used by many who are trying to figure out where to put their efforts into the vaccination rollout and trying to understand what was happening across the country in local areas. Now, I should also just note, and I don't have time to show it today, but we are still tracking and have been doing the same thing for boosters and for parents' intentions when it comes to vaccinating their children. Okay, so I'm going to turn to a series of examples in the next couple of slides that show the types of questions we asked to shed light on sort of public education and outreach efforts as people sought to understand why people were and were not seeking out vaccination. So we did this many different ways throughout the year. We used open-ended questions where we let people just tell us in their own words why they were uncomfortable getting vaccinated, what questions they had, what they still needed to learn. We did closed-ended questions where we gave people the options and said, is each of this a reason or not? Are you concerned about this or not? Lots of different ways. But at the end of the day, we learned a lot, and the sort of reasons for not immediately getting vaccinated really fell into three key buckets. And those buckets of answers really differed depending on which group of the unvaccinated you were talking about. So the first bucket are sort of those first three bullets, things about worries, concerns, information needs, about side effects, about the safety of the vaccine, and misinformation about the vaccine safety. This bucket was predominantly mentioned by people who were in that wait and see category over the course of the year. People in wait and see had real questions about the safety and side effects, and they really needed their questions answered before they could make a decision about getting vaccinated. The second bucket was this bucket sort of in the middle here, people who just said, I don't want to get the vaccine, I don't trust the government, the risk of COVID has been exaggerated. It's my personal choice. I don't have a broader responsibility. These are sort of attitudinal and strongly held beliefs about the pandemic and about the vaccine more generally. This set of sort of reasons was really prominent among the definitely not group over the course of the year. And then lastly, the third sort of bucket of reasons had to do with barriers to accessing or getting the vaccine. These are concerns about accessibility, having to miss work or miss work to recover from side effects, barriers to having to show an ID or prove citizenship in order to get vaccinated. These were things that were predominantly mentioned among lower income populations, lower educated populations, and communities of color. On the other hand, we also tried to learn about what actually influenced people to decide to get a vaccine if they weren't interested in it right away. And we did a project in June where in January we had talked to people and found out what their intentions were about getting vaccinated. And we went back to them in June and we said, well, what actually happened to you? And sort of what changed your mind? So you can see here that people were pretty good at predicting what their intentions were. In January, of all the people in January who told us they expected to get the vaccine as soon as possible, by June, 92% of them had. People in January who wanted to wait and see about whether they were going to get a vaccine, by June, 54% of them actually had gotten vaccinated, while 25% of them were still sitting in the wait and see category. Probably most interesting is in January, of the group that was definitely not or not planning to get vaccinated, a quarter of them by June had gotten vaccinated. So we wanted to use this to learn about what changed people's mind. I asked a series of follow-up questions with people, and when we analyzed that data, what really stood out was that it was personal, the influence of personal interactions with their own doctors, with their own family and friends. People said that they had the chance to talk about it with their doctor, that they already had a relationship with, and the doctor helped them understand why the vaccine was safe or why it was particularly called for in their case. They became more comfortable when they saw their friends and family get vaccinated without problem. Sometimes, people told us, my wife just bugged me so much that I finally got vaccinated. But it was this sort of data and the data from the slides before that really helped us in our own public education efforts, which I'm going to talk about in a second, but also helped us give sort of these roadmaps to groups across the country who are trying to design messages and outreach materials to specific groups. Okay, so as I said up front, in all of our work, our goal is to give voice to people, and particularly voice to those who are disproportionately impacted. And in the case of the pandemic, people of color early on were clearly identified as communities that were being disproportionately impacted by the pandemic. And we wanted to make sure we could capture those voices. So the next few slides give you some examples about how the data we captured to shed light on these communities. First of all, you'll notice that earlier on when I pointed out who at this point in time was more likely and least likely to be vaccinated by groups, I didn't mention anything about race and ethnicity. And that's because currently we find that roughly equal shares of Hispanic, Black, and white adults report being vaccinated. But early on, that certainly wasn't the case. And some of you very well must have remembered the narrative early on about the disparities that were really present. I've just circled the April data, and you can see here as an example that white adults were much more likely to report being vaccinated at that point than Black or Hispanic adults. At that time, Black and Hispanic adults were more likely to be sitting in the wait and see category. And when we looked at a lot of the other kinds of questions we asked, we found that Black and Hispanic adults at the time were much more likely to cite access barriers to getting vaccinated, like not having paid time off work, not having a trusted place to go, concerns related to immigration status, or having to provide documentation to get a vaccine. So rather than it just being a case of lack of vaccine confidence, we found instead that it was really barriers and the historically poor treatment of the healthcare system by these communities that was playing more a role in the disparities. Now you can see by the time of this second red circle that by September we found a narrowing or closing of this gap. But we also saw, and this is just another example of the link between views about how the vaccine was developed, concerns about the healthcare system more broadly, and what that meant for vaccine uptake in these communities. So note here, about half of Black adults, about a third of Hispanic adults say that they were not confident that the vaccines were adequately tested among people of their own racial or ethnic group. And when we looked at this data by people's vaccine uptake, what we saw is that even within groups, those who are not confident that the vaccines are tested among their racial and ethnic group were the least eager to get vaccinated. So for example, Black adults who were not confident that the vaccine had been tested among Black adults were the least likely to say that they were willing to get vaccinated as compared to Black adults who were confident that they were well tested. We also did a number of oversamples surveys that really focused on the Hispanic population and were designed so that we could look at subpopulations within the Hispanic population, people who primarily spoke Spanish, for example, or people who had been immigrants, Hispanics who had been had immigrated to this country. And this really helped shed light on sort of the desperate impact and some of the barriers that were specific to this community. So, for example, 58% of potentially undocumented Hispanic adults say they were concerned that they would have to show documentation. 1 in 4 Spanish speakers said they were unable to gain access to information or communicate in the language that they could understand in trying to get a vaccine. Half of unvaccinated adults, Hispanic adults, were unsure whether an immigrant was eligible to get a vaccine. So we made sure that all this type of information we got in the hands of key local and community groups, national groups who were doing outreach to these very communities throughout the last year. Now, the next set of examples focuses on how public opinion data on knowledge and on trust sources can be invaluable in the case of a pandemic. So clearly the topic of misinformation and disinformation has accompanied the pandemic from the very first days as people argued over the origin of the virus and the seriousness. And perhaps I could, ponder that this may be one of the longest legs in terms of the long-term impacts of the pandemic on our public health communication efforts in the future, the sort of massive rise of ubiquitous misinformation. Now, we saw early on how related misinformation was to vaccine intentions, and we tracked it at various moments throughout the year. But in October, we did a deep dive and we tested 8 different false or misleading statements about the vaccines. The statements included things about a government conspiracy, suggesting that the government is deliberately hiding the vaccine death rate or inflating deaths due to COVID. We also tested some blatant falsehoods like that vaccines contain a microchip, they can give you COVID, or they can change your DNA. Now, what we learned in the survey is that this belief or uncertainty about this misinformation is really common. Almost 8 in 10 people had heard at least one of these false statements and either believed it to be true or were unsure if it was true or false. 1/3 of the public either believed or were unsure about 4 or more of these 8 statements. We saw the political divides that we had been seeing throughout the pandemic, with Republicans much more likely to believe or to be open to believing this type of misinformation. And we also saw the correlation with vaccination status. Fully 64% of those who hadn't gotten a vaccine believed or were these pieces of misinformation. Further, we looked at that misinformation by people's most trusted news sources. And I think these results shouldn't really come as a big surprise given the polarized US media environment, but it does underscore that the challenge that we have, and it really helped us as we were highlighting to people the sources and where people were going and what they were learning. So certainly the green bars of those is the share of each, within each group, if you considered it a trusted source for COVID information. So people, for example, who found Newsmax or One American News or Fox News to be trusted sources for COVID information. Among those groups, 1/3 to 4 in 10 believed 4 or more pieces of misinformation, whereas for some of the other sources of news, that share in the green bar was smaller. And from the very beginning of the CVM, we knew, like certainly all of you communication professionals, that understanding barriers and experiences isn't going to be enough to help those who are designing messages to reach people with information. We all know that the perfect message is useless if it is delivered by the wrong messenger. So from the very beginning, we tracked trusted sources of information a variety of ways. Without a doubt, personal doctors always ranked at the top. And that was a message we were able to deliver to decision makers throughout the year. Keep personal healthcare providers front and center in terms of providers of information. Interestingly, people's own employers and own health insurers turned out to be trusted sources. You'll also see here that the public health agencies and authorities also had the trust of majorities of the public. Now we note that some of those, the CDC and Dr. Fauci in particular, share of the public that trusted them did fall over the course of the year, and as over the course of the political discourse got more partisan and there was more controversies, but there was still the majority of Americans still trusted these sources of information. We were able to show how polarized the pandemic how the polarization of the pandemic had played out in terms of trusted public health officials. And you see here in the red, the gap between the Democrats and the Republicans in terms of trusted information about COVID from the CDC, from the FDA and Dr. Fauci ranges from 30 to 50 percentage points. And that's a really big gap. And similarly, you can see that same gap between the vaccinated and the unvaccinated. So this sort of data, along with the misinformation findings that I just showed, really help decision makers think about who and what sources to use in their communication and outreach to different audiences. It also was a check on some of the narratives that the CDC and the FDA and other public health officials had completely lost their credibility. That wasn't true across the board. It was true, clearly, as you look here, in terms of some audiences, but it wasn't true across the board. And that was another important piece of sort of, as we talk about as being an independent source of information that we could feed back into the media narratives. Okay, finally, one last example of how we use these surveys. We also were able to use them to provide an independent, valid source of information on some key policy issues that had accompanied the pandemic, mostly through prevention and mitigation strategies like mask mandates, travel vaccine mandates, employer vaccine mandates. So for example, what I'm showing you here is we had been tracking support for requirements that employers make sure their employees get a vaccine or get weekly testing. That's of course the policy that was put forward by the Biden administration. Here you can see that views are pretty divisive across the country. The public is split, about 52% favor that, about 45% oppose it. But know that really what that is reflecting is the stark partisan divide underneath that total, with 8 in 10 Democrats supportive and 8 in 10 Republicans opposed. Now, this sort of divisiveness and partisan split turns out to be virtually true across the board with all sorts of requirements and mandates, no matter what you ask about. But since we were also measuring experiences, what we found is that employees who were at employers who provided paid time off or encouraged vaccination were more likely to report being vaccinated themselves. And this held up even after we controlled for all the other factors that we know are associated with vaccine uptake. So this sort of data allowed us to show where leadership among employers might be needed. That is with or without a federal or state vaccine mandate, employers had a means to encourage uptake independently by providing paid time off and by encouraging vaccination among their workers. I'll note that we found a very similar thing in terms of the role of schools with respect to kids vaccination. Those parents who said that their schools provided information and encouragement about vaccinations were more likely to vaccinate their kids, even after we controlled for all the other factors that you could imagine would impact decision-making. Okay, so that was a quick, big look at some of what we did. And how we think it was useful to communication efforts and to people on the ground. But as I said at the beginning, if we just did all that work and nobody saw it and it just sat on our website, it wouldn't have been helpful. So what did we do to disseminate it? How did we make sure that people had it? The first thing we did is we had to make sure that we were timely and relevant with our data collection process. So basically what we were doing is we were designing a survey in week 1 of a month, we were fielding it in week 2 and 3 of the month, and we were releasing that data by week 4 of the month. We also would do smaller focus reports sort of in between as we were working on the next data collection effort. But overall, we probably wrote 40 individual KFF reports and releases based on the 12 CVM surveys we'd done over the year. We continuously had an updated dashboard on our website. We used social media. We used other means to get the data out to the media. We did see sort of a big uptake in the press. Many new news outlets wrote about it, still write about it. I would say there's really not a day that we don't get in our clips that the CVM isn't cited somewhere. And so that's certainly a great first step. We've talked to lots and lots of reporters. But I think even more important to getting the information in the hands of people who could really use it were all the many presentations and the briefings and the conversations that we had with those who were on the ground. I've just put a few here, but we did briefings, with HHS and CDC and the White House COVID Equity Task Force. We spoke at events that were pulled together by the National Academies of Medicine, the National Association of Broadcasters, who has all the local media stations across the country. We did a number of webinars for them. We did things for the National Association of Community Health Workers, who were leading a lot of the on-the-ground efforts. So the bottom line is that none of this would have mattered if we hadn't found a way to make sure it was getting in the hands of people who needed it. In addition, we worked with our social media impact team, who had pivoted their own ongoing work on Greater Than AIDS, which had been a long-standing campaign, a project they have been working on with public health, state public health departments across the country for years. They pivoted that to the Greater Than COVID campaign. And they basically used all the learnings from our survey collections to work with their partner, the Black Coalition Against COVID, to launch an effort called The Conversation Between Us About Us. Basically, they used the messengers that we had learned in our research were the right messengers, healthcare providers who looked like and talked like the audience. And these healthcare providers were answering real people's questions and concerns that we had captured in our research. There's a library of, I think, more than hundreds of questions and responses. Unfortunately, I am not technologically talented enough to show them and share them with you right now, but I'm really eager for you to go and explore them. I think you'd find them really interesting. The content was shaped by all the findings that we had been gathering. Later in the year, that effort expanded to the Hispanic population. I don't know how I did that, sorry. Had expanded to the Hispanic population with materials and videos in both English and Spanish. And it has subsequently expanded to work, to do work with the American Pediatric Association on a series of pediatricians speaking to parents about the importance and answering their questions on childhood vaccinations. Okay, I know that was a lot, but I do just want to take 5 minutes or so and take a 180-degree turn, because I want to very quickly do a similar look at some of our polling around the issue of lowering prescription drug costs. And I want to do this for a really particular reason. I want to show how similar goals in the use of public opinion data can be used in a very different scenario with a very different time frame, right? This is a debate, lowering the cost of prescription drugs, that has been going on for decades. It was not a short, quick, evolving situation like a pandemic is. So I just want to do this, and it's just a couple slides. So first, so tracking people's experiences, right? I said that's one of the main things we do. Well, for decades, we have tracked people's experiences with prescription drugs and their costs. We focused on measuring experiences of what happens in their real life, particularly among those who are most at need. In this case, it was the chronically ill, those with the lowest incomes, the uninsured. So you see here, prescription drug use is ubiquitous. 6 in 10 report taking prescription medicine at least every day. 1/4 of us take them 4 or more in a day. 1/4 of us have trouble paying for it. 3 in 10 say that they don't take their medicine as prescribed because they can't afford it. They either don't fill prescriptions or they cut it in half. Similarly, in our role is trying to help keep a finger on what's people's perceptions and their views of the healthcare system is, we've seen throughout the years that the public has a love-hate relationship with the pharmaceutical industry. They very much appreciate their products. They recognize that the drugs make their own lives better and the lives of all of them around them better. On the other hand, they believe that the industry is too focused on profits and that those profits are too high, and that that's a major reason why prices are so high. Therefore, when people, because they think prices and profits are too high, virtually any solution that we run past the public and that is on the policy table, it sounds appealing to most people. Because at the end of the day, they really just want, and in many cases they need, their own drug costs to be lower. And they honestly don't care that much about how lawmakers plan to do it. So you can see here as one example that in 10 out of 11 potential policy options that we've run past the public that have been on the public agenda, on the policymaker agenda, 10 of the 11 of these are have approval by half of the public, right? There's only one here that people will really tend to dislike at the face of it, allowing Medicare drug plans to exclude more drugs, right? Don't take my drugs away from me. But almost everything else that's been on a policy agenda is seen as a good idea by people, basically. So this sort of result helps the media, journalists, helps policymakers see kind of the constraints and the opportunities that they face with the public as they think about what policies to pursue. Now, One of the options that's been on the policy agenda for a very long time and has more regularly broken through to the public is whether the federal government should be allowed to negotiate prices on prescription drugs through the Medicare program. On the face of it, it's a policy solution that people just understand, right? We've been asking about it for a long time. This is just data back 6 years. We asked 8 different surveys in 6 years, and at least 8 in 10 people favored this idea. It just makes sense. Why shouldn't they be allowed to negotiate prices? It's kind of a basic American value of business. We negotiate for prices for cars, for houses, all sorts of things. Why not for drug prices? And so people just say, sure, let's do that. That's great. Well, as I said, one of the main things we try to do with our polling is shed light on how the real world debate is being viewed and how it may impact the public as a way to make sure that those in the media and policymakers have the same information at their disposal as the special interests who definitely make sure they learn what arguments and messages are most impactful to use to promote their positions. So in a sense, what we try to do is we try to mimic the debate and show where opinion is dug in and where it might be more malleable. So in a $4 trillion healthcare system, you can bet that the special interest groups spend time trying to understand the messaging and the framing. And we just try to illuminate that same messaging and framing in a public domain. So for example, back in May, we asked the general question, do you favor or oppose allowing negotiation? 88% say favor, like we'd seen overall, like we'd seen in the past. And so then we had some follow-up. So, well, what if you heard, do you still favor, or would you favor or oppose these negotiations if you heard that it would save people money? Yes, sure, of course, that's a good idea. What if the federal government could save money by paying less for drugs for people on Medicare? Yeah, sure, that's great. That still sounds like a good deal. Well, what if it could lead to less research and development of new drugs? Well, now that doesn't sound like such a good deal to me. Right now, 65% are opposed to that idea. What if it could limit people's access to newer prescription drugs? 65% again are opposed. So this sort of data helps people understand what are the pieces of information that could move opinion or that people could scare them away from a policy position. So we make all our data publicly available to inform all audiences. And the pharmaceutical industry picked up that finding that suited their purposes, and the one that if people heard that negotiation could lead to fewer drugs and support, that opposition rose to 65%. They used that finding in a series of pretty long-running advertising campaigns that was really targeted at lead audiences through Axios and Political. Now, they didn't make that finding up, right? They cited the one finding exactly right, and they cited us as the source. But if you look at the range of responses from the previous questions, I imagine you might draw a different conclusion, or at least have a conclusion that it is a more complicated picture than just the way it was presented in these advertisements. Later in the year, the debate had more solidly crystallized, and the public was hearing more regularly from opponents and proponents. So this time, we really tried to mimic the proponents and the opponents of drug negotiation and what they were saying in public discourse. So we looked at their statements in the press and in their advertisements. And what we did is, after we got people's initial views on price negotiation, again, we found that 83% were in favor of such a thing. We read people, both the opponents and the proponents' strongest arguments. And I'm not going to take the time here, but here's the text of what we read. And then we re-asked everybody, after you heard both of these things, now do you favor drug negotiation or not? And you can see here that the total favor before was 83, the total favor after was 83. So the arguments didn't really have the same kind of effect on opinion that we had seen back in May, when we had just done one argument at a time. It did soften the strongly favors, right? That fell from 52 to 45. That was largely among Republicans, were sort of the most soft in that. But overall, this policy proposal was still very favorable among the public. I should note that we also asked about how convincing people found each argument separately. About 1/3 found the argument against various somewhat convincing, about 8 in 10 found it unconvincing. So lastly, and I think importantly in this case, I wanted to note that the basic premise behind the opponent's argument against price negotiation, that it will cut off innovation in new drug discovery, wasn't something that resonated with the public by partisanship or by age, as you see here. When we asked which came closer to their views, that drug companies needed to charge higher prices to fund innovation, or they could still have innovation even if they kept their prices lower, most people believed the latter, right? Now, I wanted to share this example of how illuminating what in effect is a message testing, a message framing exercise. We know that the money interest, we certainly know pharma was undertaking this sort of research, but what we want to be able to do, one of the ways we think public opinion available in the public marketplace can be really helpful, and sort of in communication in the service of social change, which is, I think, why many of you are in this program, we believe that everyone should know why certain frames, certain words, and certain arguments are getting put forward. And it's this sort of research analysis and making that clear that we think is a means to do such a thing. Okay, just to sum up, so I showed you examples of where we use our surveys to fill a need as an independent source, right? Certainly in the argument message testing in the prescription drug case, certainly by providing timely, regular messages of dynamic nature of vaccine uptake in the CVM case. I showed you examples of how we use our data to make sure that the public has a voice in their system, especially often those people who don't have it. Certainly, I showed you those examples in the CVM case with the Black and the Hispanic oversamples, the barriers or the worries they had about missing work or providing documentation. In the prescription drug example, the data on the chronic conditions or those people who are heavy user of drugs. I showed you examples of how we go beyond measuring opinion to measure experiences, knowledge, and how that can be helpful in the context of policy debate. Certainly in the CVM case with misinformation and where they needed information, then the importance of conversations with doctors and pediatricians. And in the drug debate, the data on skipping or postponing care, or not seeking their prescriptions. And then lastly, I showed you some examples where I think the data pointed to where leadership is necessary. In the case of the CVM, policies to mitigate further transmission that could be influenced by employers and schools. And in the prescription drug debate, I'm not sure I made it quite as clear, but we've had this long-term trend on favoring prescription drug negotiation, but it's still not policy. This clearly isn't a case of whether the public favors or oppose it anymore. This is a case of leadership politics and whether leadership is actually going to ever decide that that is a policy to implement or not implement. Before we turn to questions, which I'm really excited to get to, I just want to do a couple quick caveats and cautions. Polls tell us where the public is, but as I've said before, they don't tell us what's right. And it is important to think about when leadership is needed or when the public needs to be brought along on some sort of issue. Polls tell us where the public is at a given point in time, and that's fluid. They can be influenced by events and what leaders say and do. We've seen a lot of dynamic changes over the course of the pandemic, and that has been because the nature of the conversation has changed so dramatically with each new variant, with each new mask mandate or vaccine rollout or the booster rollout. 3 is really important. The technical issues matter a lot. You've heard me use the word representation quite a bit today. We really care about making sure that when we say, X% of Blacks or X% of, Hispanics or X% of the young and X% of seniors think something, that I have a lot of confidence that I know I'm doing the best job representing the views of that population. That's hard these days in survey research. And these technical issues matter a lot about whether you can feel confident in your data. And then, of course, there are limits to polling on complex policy solutions. We probably push the limits, especially sort of when we're talking about prescription drug debates or things like that. But that's something else to think about when there are limitations of how polling data can really help you in terms of understanding communication efforts or not. And then the last thing, at least I hope you take away, is that doing the work on your own doesn't matter if nobody sees it or gets it, and the dissemination ends up being incredibly key. And so with that, I thank you. I'm going to stop sharing my screen. I hope you're still with me. Hi, there you all are. And I know that was a really quick run through a lot of stuff. I am open to talking about anything, and I think we have plenty of time to do that. So here I am.
Well, we got a lot of questions. And We got a lot of questions in the chat, the main chat, and Scott will be moderating those and highlighting those. But I will start as promised to our students with the pipeline and me to ask questions. I'm not sure if due to Zoom bombing, we're putting people on camera, but here are the questions. There's some interesting questions. So question from one of our students is a pediatrician, actually, Nina, and is interested in surveying children and adolescents and their views on vaccines and other health issues. So her question is, I mean, part of the question is, what kind of work do you do with children and adolescents, and what kind of work do you suggest doing? Should we be amplifying, Nina asked, should we be amplifying the youth voice in influencing policy as well as empowering youth on their own health, as well as serving as role models? I got vaccinated and so can you.
Yeah, no, that is a really excellent question. In the past, in our work, we have, we used to much more regularly than we have recently done surveys with young children or teens. We've done in a lot of our work around sexual health and HIV and education efforts. We really have done that. It is a hard population to survey, as you can imagine, but there are means and mechanisms to do so. We haven't done that so far in the case of the vaccination rollout. I think it's super interesting and important. I think that the timeliness of when vaccines were happening and choices. One of the things we did ask is whether the parent had a conflict with their teen about the vaccine, or whether their teen was interested in the vaccine. And there was a little bit of that happening in families. I think probably the most important thing that we know right now about vaccination status is that it tends to go with the household, right? So parents who have chosen to vaccinate themselves are much more likely to have chosen to vaccinate their teens and their younger children, and then the opposite is true. So I think really where this kind of research would be really helpful is in those households that a teen wants to be vaccinated and their parents are not, or vice versa. And I don't know of anybody who's done work on that, but it's a really important topic.
I'm glad you mentioned that, because that was a related question from another one of our students who asked that very question, curious about the teens who want the vaccine and parents don't, divorced families. So, and Jennifer asked the question, said the issue is not a political one for kids, according to her observations of her kids, but for their parents. So it's a common theme among her daughter's friend group. So this seems like an interesting subject that we'll be looking into as time goes on.
Sure. I totally agree. And I do, I mean, we've talked in the past about, one thing that is going to emerge from a year of talking about vaccinations, right, is everyone has a whole new language around it, right? Before this, we used to talk about sort of the anti-vaxxers, and the people who are not getting the COVID vaccine are not necessarily anti-vaxxers at all. And they'll be the first people to tell you that they've gotten all their other shots and they get their kids vaccinated and all that, but this is something different. I think that we've sort of empowered teens and young adults to have these kind of conversations because we've been having it as a national conversation. I don't know if we know what the outcome's going to be, if we know if this sort of the conversation we've had where it has been so polarized is going to end up eking into other vaccination conversations or not. I think it's an open question. I know Scott and Chris are really interested in measuring that going forward. I'm certainly interested in measuring that going forward, but I'm not sure if we know yet.
Oh, great, Molly. I mean, it's just an incredible presentation, and I know you rushed through it, but very, very data rich, and just did a phenomenal job of just showing the trends and the thinking and the complex nature. And I want to thank you both on behalf of our program, but I also know our dean is on, a number of other chairs and distinguished professors, both internally with our CUNY family, shall I say, but even people in Washington who put questions in the chat from Leader Research America and others who use your data to really affect policy. So I want to thank you about that. And particularly, I think one of your second objectives of give the public a voice through data, and your probability-based data, the way you've been conducting surveys for your career here with KFF has just been terrific. And thank you for sharing that. I'm going to keep the question on the theme of adolescents and child vaccination, because one, we all don't have great data that we're getting that might not be accurate from the federal government on a daily basis. But I did have a call earlier today, and I heard amongst some leaders who've been consolidating it, that last week is one of the worst weeks we've had for 12 to 17-year-olds and 5 to 12-year-olds on vaccination, as well as boosters. everything seems to be dropping off, and whether you want to call it, I don't know what we call it. If you say a new lexicon, is it a fatigue, or is there something that's going on that you might see from your perspective, or something that we could measure and try to understand?
Yeah, it's a great question. I was just pulling up on my screen our latest data. So in January, what we saw is that, particularly among the teens, let's focus on that. Vaccination had really stalled out in the late winter. So by September, we were showing about 48% of parents telling us their teens were vaccinated. And by November, that was still at 49%. But something about Omicron did jive people to get in and get their jabs. So by January, that was up to 61%. So there was sort of a rapid return to increasing shares between November and January. And I am almost certain that it's Omicron that pushed that. Similarly, that is sort of similar for the 5 to 11-year-olds as well. But we are, we do expect that to sort of taper off again. The Omicron surge is coming down, that immediate risk is coming down. And you are going to be stuck with this fact that I think we're going to end up with teens at the same place we have adults, which is a share of adults who are not willing to vaccinate their teens and a share of teens who are not willing to get vaccinated. And, the decision, what we've heard from parents on this is very similar to what we heard from adults early on when they were thinking about themselves. They're worried about the safety of the vaccines. They're particularly worried about the long-term effects. When it comes to yourself, you're 50, you're 60, you're getting a vaccine, long-term effects, whatever, But when you're thinking about your 5-year-old, your 11-year-old, your 15-year-old, they really worry about that, and they worry that the science isn't there yet. So the two things that we've learned from our work so far is the importance of pediatricians. And the point here, and I'm sure Nina will agree, is that pediatricians are used to having this conversation, right? What is like the number one conversation pediatricians have with all parents is about vaccinations. They are the one sort of group in America who is really trained to have these conversations and is probably used to having these conversations. What we have found is that parents who've had conversations with their pediatricians found them very helpful, and it did help many make the decision to get vaccinated. It wasn't always that case. We certainly have seen some data that a small share of people who talked to their pediatricians ended up not deciding to vaccinate their kid. We don't know what the nature of that conversation was, whether it was, I doubt, you don't know whether it was the pediatrician saying it wasn't necessary, as opposed to just the pediatrician not wanting to provoke or alienate the audience member or their patient who might have a political reason not to want to get the vaccine. But what I'll say as a last point on this is that the political polarization does matter for teen and kids, but there's other things that matter too. And the fact that kids and teens get so much less sick from COVID and a bunch of other factors, those things do play in when you're talking about risk reward. If you're worried about the safety of something and you know that your kid really is most likely not to get very sick, it is a harder conversation. And these are going to take these one-on-one conversations between pediatricians and people, and that's the most powerful way to go.
Oh, great. I mean, thank you for a comprehensive answer. I know you've done a lot of thinking on this, and I'd like to just turn this over also, as we've been talking about national data. A lot of our work is New York City and New York State and other data, and Professor Nash has been conducting one of the surveys for many, many years with household surveys and others. I know has some questions here. And some of this is also in the chat that we'll come back to in the mandate question and other pieces to file away. But Dennis, over to you.
Thanks, Scott, and thanks, Molly. I've been following the KFF polls for so throughout the pandemic. They're useful to us in so many ways. I just want to turn to this question between about what you guys are seeing nationally and what we're seeing in New York. Like, I'm thinking specifically about the differences by race, ethnicity that you showed. And like you alluded to, the narrative in New York City very early on was, very critical of Black and Brown communities for not having higher vaccination rates. And of course, nationally, that is flipped, and it is the Black and Brown communities that are having the highest vaccination rates in Asian communities as well. Part of the disconnect that I'm seeing, we're not seeing that in New York, what you're seeing nationally, and there may be, part of the reasons may be political ones. But I wonder, the other difference is that we're estimating our vaccination coverage based on what's reported through vaccine registries and immunization registries. And you guys are getting it from polls. And I'm wondering if you've explored where there may be disconnects, because I'm beginning actually not to believe some of the information coming from registries. For example, 110% of Asian New Yorkers vaccinated, things like that. And this is starting to show up nationally too. Have you had any thoughts about that?
Yeah, we have spent an enormous amount of time trying to figure out what our representative polls look like compared to like the data that the CDC is collecting, that others are collecting. As I said, what KFF does, our policy team, our racial health equity group has been collecting from each and every state the data that they have by race and ethnicity. And we have seen, at every stage, a different picture between the data they're collecting versus the data we're collecting. And what we've sort of come to believe is that the answer is somewhere in between, right? That these administrative sources are great at one level, but they're not great at sort of details. There's also, we know that there's problems with whether vaccines are getting counted as a first dose, a second dose, or a booster. So like our data, just as an example, if you looked at the very first chart where I was showing sort of trends in uptake, it matched sort of the national CDC data pretty well until boosters came out, and then their data started really looking like everybody was vaccinated, and we were seeing really stagnation. And what I think everybody has come to believe is that their data wasn't doing a very good job just disaggregating whether it was a booster shot. It was a shot. Our shots matched, right? The number of shots we were counting and the number of shots they were counting was matching, but what kind of shot it was. So at the end of the day, I think that one of the things that we've learned through this pandemic is that our public health system and our surveillance system and our data systems really need a massive upgrade. And we know that there were, problems have been everywhere. And everyone who's working on the systems has done the very best they can. And so this is a case where what I have said to everybody is take all the data and see what it tells you together as a story. And, you can't cherry pick one finding or another. But what we've come to believe when we look with our colleagues is that the true answer is somewhere probably right. We're probably close to right. And some of those, it's probably, we might be a little high and these administrative sources are probably a little low.
Thank you. That makes sense to me too.
Well, yeah, definitely in terms of an upgrade, it'd be nice to use that language to translate quickly, which hasn't happened. So Molly, I have another question. Some have come up through the chat of the use of language, and particularly how you're asking the survey questions. So, mandates versus requirements, vaccine credentials versus verification schemes versus passports, boosters versus fully vaccinated. How are you finding, how you're doing it, and probably the most sophisticated ways that you did show that you've been able to hone in on the reality. But secondly, with the changing sentiment, how do we get at what the, lack of a better term, right or best terminology is that we ought to communicate and to help move forward and get people vaccinated, at least in the vaccine monitor discussion?
Yeah, no, that's an excellent question. And it's actually really kind of one of the main points of why we do the work that we've done. And sort of, of all, there's lots of reasons why we do it. One of the reasons is to shed light on this, right? Like words matter. And we've historically done lots of things where we've asked half a sample with one word and half a sample with the other word. And you can show to people like how important that one word was. And I think this is exactly that time for that kind of work. We, in the context of the vaccine monitor, we have been more focused on using the words that are being used in the national discussion as opposed to trying to change that national discussion, right? Or trying to find the right words. We really just haven't had the survey space, the real estate to try to do any of these word testing when there's been just other things that seemed like more of a priority. But it's certainly exactly a perfect use of survey research. You ask the question a couple different ways of different, equivalent samples. You see what that impact is. You guys know, you learn it in your method classes. You know how to do this kind of stuff, but it's then making that data available and making it clear to people. Some of the work we've done on this language testing that matters a lot is, around debates like about Medicare for all, right? Universal coverage, making sure everyone has access to health care is kind of a apple pie thing. Everybody loves that. They actually even love, the idea of sort of universal coverage. That's a really positive phrase, but you say single payer, or you say a national health plan, and, support plummets for the exact same thing. The reason Medicare for all became the term was because Medicare was so popular. Now it has, since Medicare for all has taken on its own new sort of political dimension. But so the bottom line is, I think this is a perfect use for using survey research. We haven't done a lot of it because there hasn't been time
Sure.
or space.
Okay, I think we had Marisol who was ready to ask a question, but had some mic problems. I don't know if she's still available here.
I just saw in the chat that Obamacare and ACA are different. Yep, exactly.
Yeah.
I'm available. I just wanted to make a statement with regards to vaccination and like the youth, because I currently work for an after school program. And one of the current trends that I see in a lot of the same statements that parents are making is their distrust with government, and in turns not feeling confident in what the long-term effects can be with having their children vaccinated who are under a certain age. And also, I know that lack of education plays a very big role in that as well. A lot of these families are of immigrant status and live in an impoverished state. And so I think lack of information, lack of resources, and lack of understanding all contribute to why a lot of families are opting out of having their younger children vaccinated. And that's what I wanted to say.
Yeah, absolutely. Totally consistent with our data. Exactly.
Okay, I'm going to, our Dean has his hand up. It's great to see you, Dean. I'll turn over to.
Thank you, Mollyann. Very, very instructive and very helpful to us and to our students. I just wanted to point out one factor. You mentioned rural, you mentioned perceptions, but how about access? And the assumption that we willfully are able to vaccinate or not. I think what was most telling and very interesting was the time lag between intentionality to get the vaccine amongst those that were totally sold on it in January, and it took them till June to get it. And I'm wondering whether there is a juxtaposition between perceptions and acceptance and access to care, and whether that expounds the lag that we are seeing in underserved groups, which tend to be racially defined sometimes, unfortunately, and in rural areas. I'm only asking that question because last year we did a poll amongst those that were 65 and older in the very early stages of prioritizing the vaccine, and in Harlem and in New York, and we did not find any difference in rates of vaccination amongst African Americans at 65 years and above and the rest of the population. And my fear is sometimes we perpetuate stereotypes and prejudices unnecessarily. So humbly, I ask that question, and I'm sure you have a lot of insights to add. Thank you. Thank you for today. It was lovely.
Oh, you're welcome. It's great to be here, and thanks for supporting such a great program. I'm so excited about this this program that you have going on here. Yeah, no, of course, as I showed you, there was access to care barriers, not having a trusted place to go was a really important reason why many people, particularly in the wait and see group, didn't seek out the vaccine right away. Again, those responses were disproportionately provided by people who are lower income, people who are lower socioeconomic status, and people of color in certain communities. Again, you're right, though, that we saw that those gaps in access were largely dissipated over time. The rural situation was a little bit more complicated. Rural vaccination status lagged behind sort of the national norm for a variety of reasons, some of which is that lack of access, getting it, although I've heard many stories of people who drove to rural areas to get a vaccine earlier on when they couldn't get them in the city. But the other reason that, politically, the rural areas tend to be more disproportionately red states and Republican states. So there is more of those beliefs in that posed to be against this idea of getting vaccinated. What we had found when we did some additional digging and looking and some regression analysis is that the lag in rural areas of getting vaccinated went beyond just partisanship. So even after we controlled for other things that we knew impacted vaccine rates, there was something different about living in a rural area. And when I did a number of presentations for groups that were working at vaccination rates in rural areas, and what I often heard from the audience was like, look, in the city, you're seeing people everywhere. I go out my front door and I don't see another person for a mile, right? Or 2 miles. It's really easy for me to keep my distance. I don't need that vaccine, right? So there is something about living in a rural area that was different, but you're right. Access, attitudes, all these other things also did play their role.
Yeah, I just needed to add, there is a stint of my life where I did live in Nebraska, and I know the rural Nebraska quite well. And the thing that is very interesting there is also very limited access to media. Mm-hmm. And so all of them listen to a certain radio station. We talk here about different points of view and about the internet and so on. And in many rural areas, the influence of media is very unipolar. So it's like, it's Chris Palmetto. He is a star in that rural area. They listen to his program every day at 9 a.m. and his word is the last word. So if Chris tells them go right, they go right. If he tells them go left, they go left, because there's nobody else for them to they don't listen to anybody else because there isn't anybody else to listen to. So the specificity of media dissemination in rural areas also is worthy of study, of where do they get their information.
Mm-hmm. Absolutely.
There is no competition. Chris is it.
Great.
Yeah, our reality is indeed a challenge, and we've tried, lots of different ways, not only measuring but also turning some of this into action with the New York Vaccine Literacy Campaign, with a variety of other pieces that we're engaged with, and a couple of students and people who are engaged with it have asked some other questions in the chat, and I'd like to ask you, if you don't mind, on the trust issue. And I mean, thank you, knowing you've heard and you've. And thank you for the work that you've been both as an advisor with our Commonwealth Fund Research on Trust and now with our latest work. So I know you've seen and heard our qualitative stuff, which is quite limited, if I could say that, in comparison to obviously the great depth of surveys. So how do the questions go to, one, reaching the undecided parents who might still not have trust in the vaccine or the system for their kids now? And then the second one that kind of links to that, how have you seen those behaviors, intentions in a way that we now as public health messengers can avoid the missteps that have happened in the past on trust linking to Tuskegee and some of the others?
Yeah, I'm going to take the second one first because it's the thing that I mentioned before that I think misinformation is going to have long legs coming out of this pandemic, public health misinformation. The other thing that I think has really long legs coming out of this pandemic is that our public health officials, systems, scientists are now kind of in the same bucket as everyone else in terms of America's distrust, right? We were built. My brother is a colonial American political history scholar, by the way. So he always tells me our country was built on distrust. Like, when you go back and I don't know, I didn't read all this, but you look at the Constitution, you look at the Continental Congress, there's a lot of distrust of government way back then, right? And so we're built on that. And we always have it as part of the fabric of what makes us American. But over the last handful of years, that distrust that we sort of had of our political system and other things has evolved and engulfed all aspects. And I think what the pandemic has now made front and center is that same level of distrust has now come to the public health infrastructure, to the public health officials, to the fact that we're seeing it so partisan and so politicized. And that I think has long legs and is something to really worry about, and really this rebuilding the fabric of trust in this nation is gonna I don't know how you do it. I don't know what happens, but I think it's going to be on all of us to be thinking hard and working on that for the next 10, 20 years. In the case of reaching the undecided parents, I think that the focus has to be on those parents who are vaccinated themselves, but are still undecided about their kids. I think that trying to get the parents who have decided not to vaccinate themselves to vaccinate their kids is just like almost an impossible challenge. So I think the first thing is you focus on the parents who are vaccinated themselves. And then you can talk specifically about what their concerns are about their kids. And it's just a case of finding their trusted messengers and finding people that they believe. So what we have found over and over again throughout this pandemic is hyper-local, hyper-local, which is why I've been so impressed with a lot of the efforts you all have been involved in New York City. Like, so this is, parents in the school, it's the teacher, it's, the people you have relationships with that have that maybe that ability to have that one conversation with that parent that actually will change their mind. We do harp on the importance of pediatricians, but it's very true that many families don't have a source of healthcare or a pediatrician that they regularly use that they trust. They don't have those links in the healthcare system because our healthcare system has really failed, whole segments of our population. And so that's going to be a challenge, right? You can't rely on a pediatrician who doesn't have a relationship with a parent. So it's going to be, a step-by-step effort. And I'm just going to encourage hyper-local, community-focused, efforts that can reach schools, reach parents within schools. And it's going to be that kind of effort, I think, to make a difference.
No, I mean, thank you on that. And Nina, you've been active in the chat. I'm just not going to let you get away with only being in the chat. Nina's our resident pediatrician in the Health Communication for Social Change program and works with AAP, the Academy, both locally and nationally. We've been on a lot of calls. We're trying to put our heads together. Nina, you're asking some tough questions, and you've got the world or at least national expert that may be able to answer here for you.
Yeah,
I'm not monitoring the chat. So if you've asked questions,
so Nina, if you can turn on your mic, please. And
okay, yeah, thank you. This is just wonderful. It's been such a challenge, and it's great to hear everyone's perspectives. Yeah, for the vaccine hesitant, it just seems like it's not going to be a one-off. this is a longitudinal game. Parents are often like, well, I'm going to wait. And I feel like they think the pandemic's going to be over and they're not going to need to do the vaccine. And so I think part of it's telling them, no, this is not over. But that, I'm not sure if you have information on that when they say, what are you waiting for? One, it's to be tested, but I have a feeling they're thinking it might be over, but I'd like to hear your thoughts on that. And the other is just multiple opportunities to educate. So educate and then say, and they're like, well, I don't think so. And then you go back to them in a month or so and just keep on doing that. And I do involve the youth and like, do you want it? When you talk to your parent about it and making it sort of, a dyad type of decision.
Yeah. No, I mean, what we've learned so far from parents is it's mostly the safety concerns and it's just too new and the longitudinal concerns. So you're exactly right. I think you're exactly right about it. This is not one and done conversation. I mean, this is about building that relationship and keep coming back to it. I do think from our data that we showed that Omicron, it was so ubiquitous that did spur some vaccination. But now that that's abating, I'm sure we'll see abating vaccination rate, right? So I do, I really love the way you talk about this as a long game, because it is, a marathon, right? The coronavirus is here with us. Hopefully we can go back to more of what we're used to and having, but what's going to happen next winter? What's going to happen the winter after that, right? So this conversation is nowhere near over, and there's still lots to learn. What I will say that we learned with the adults is the more your friends and family got in, the more you saw it was easy, and the more the kids can see that they have more flexibility and they have to wear the mask and they don't have to do this stuff, the more they're going to lobby for it as well. So I do think it's having that long game viewpoint and just being, sticking with it in some cases. There's no one and done here. You're exactly right.
Great. No, thanks. We have one last question, Heather, and then I'll do a quick wrap up, but in the next couple minutes, please.
Thank you. Thanks for this wonderful program. It's been really great for me. I am the annoying public health MPH parent at my kids' elementary school. And so we have had amazing success. We've got the vast majority of our kids in M95Cs at school. So we've had great success with communication, and we've arranged for a pop-up vaccine clinic to come to our K-5 school on the 28th and then again 3 weeks later. And so my specific question is, how much outreach do you think is beneficial directly towards the children? Because our principal has suggested that my son and a couple of other kids that were vaccinated really early do a dialer where the kids are talking to the kids about what their experiences were like. And how impactful do you think that would be?
I mean, as long as you don't get the blowback from parents, I think it's brilliant. I mean, you just have to moderate that risk. Do they think you're going around them? And you want to be respectful to the parents too, and their ultimate choice. But I mean, it's no different than any other conversation. You use kids to help other kids learn about climate change and learn about how to put the garbage away, sort the garbage, whatever. It's exactly the same thing. I think it's a fabulous way. Kids want to know, how bad did it hurt? How sick were you? They're scared of it too. A lot of us were scared of it. We saw people got really, really sick and those sorts of things. So I think hearing from, I guess maybe that's a point I haven't made clear enough. In all of our open eds throughout the entire year, what was most impactful was hearing a personal story, right? A personal person, whether the person changed their own mind and you heard them describe, your friend, oh, my friend changed their mind because of A, Y, and Z, and then that made sense to me. Or because my friend told me that this is what happened to them. Similarly, when friends told friends that they were sick for 5 days and it wasn't worth it, and now they have long COVID from it, that was not very helpful, wasn't helpful, right? So this, these informal, and this is why I keep talking about hyper local, there's not a universal theme in everything we have, every piece of data we have collected for 14 months or whatever, is that the importance of these informal and these personal networks in terms of affecting people. And as I said, you know, we saw in our data that if you were at a school that was encouraging, that was providing pop-ups, that was giving information, you were more likely to vaccinate your child, even, you know, controlling for all the other demographic factors about you. So, you know, there is evidence that this stuff can really matter. So.
Okay, great. And we have already communicated with parents. We've already started that parent communication.
I'd love to hear the result of that. That sounds like a brilliant thing to do.
Okay, great. Thank you.
Great. No, thank you. And thanks, Jenny. I'm sorry. We're just going to have, we're out of time here. And that means you have to put the questions in the chat. We'll keep this going. Molly, this has just really been terrific. And, you know, I should really say what Dr. Brodie had done early in her career with Chris, that was so mentioned. And when you came back to even the importance of mentoring, I think that's why a lot of us who are both faculty, students, former students, alumni, all of us who are on here, the real importance of turning data into action. And in this case, of course, public opinion data of being so important in nothing that's more important, in my view, of the common currency we all have of communication and health. So that's what we're all about in the whole health equity and our mission with CUNY School of Public Health. But I don't want to be the final word, so I know that Chris might have something to say. Then back to you, Molly, any pieces. We're really excited about and thank you again for the support here today, but also for future interaction. But before that, Chris, over to you.
I'm speechless. No, it was great participation. This is the best of a grand rounds online. I mean, we'd love to have it in person, but the chats are demonstrating how these online sessions can be so productive. And it's just been really great conversations with you're talking to each other. You're commenting on Molly's talk. You're asking questions. So it's been really very wonderful to see this come out as well as it did. So thanks so much, Molly. Thanks everybody for your questions and for your participation. And we'll see you next time.
Thank you so much for having me. And I'm happy to try to answer some of the questions offline. Maybe Scott or Chris can send me some and I can get some answers to you all. But thank you for everything. And thank you for your interest. And thank you for your commitment to public health communication.
Yes, well, thank you. And thanks for your tireless efforts to do this in the time today with about as valid and as insightful that anyone could be. And really thank you for being a part with our Health Communication for Social Change group. So with that, I think we'll close this. And this is recorded, so we know some other students will see this. And thank you for offering to answer other questions. I know we'll keep the dialogue going.
Thank you. Good night, everybody.
Good night.
Good night.
Thanks.